Can you examine all 12 cranial nerves? And more importantly, can you understand what an abnormal finding actually tells you about the location of neurological lesions? Cranial nerve examination can seem complicated because there are 12 different pairs of nerves, multiple functions, and several clinical tests to remember. But instead of simply memorizing them, we are going to understand them. In this video, we'll go through the cranial nerve systematically, what each nerve does, how to examine it, what you should normally see, and some important clinical findings that can help you localize a lesion. So, let's begin. Before we begin, let's take a quick look at some of the basic equipments we may need. A visual acuity chart such as Snellen's chart, a pen torch, a cotton wisp, a pin, a watch or a paper, a reflex hammer, a tuning fork, and when assessing olfactory nerve, familiar, non-irritant substances can be used to test smell. The exact equipment required will depend on which cranial nerves you are assessing and the clinical setting. So with everything ready, let's begin with the examination. Let's start with the cranial nerve 1, the olfactory nerve. As the name suggests, it is responsible for sense of smell. To test it, each nostril can be tested separately using a familiar non-irritant substances. Ask the patient to identify the smell while the opposite nostril is occluded. However, remember that cranial nerve 1 is not routinely tested in every basic neurological examination. It becomes particularly relevant when there is a history suggesting possible olfactory pathway involvement, such as head trauma or anterior cranial fossa lesion. Next is cranial nerve 2, the optic nerve. The optic nerve is responsible for vision and also forms the efferent limb of pupillary light reflex. There are four important things to assess: visual acuity, visual field, color, and the pupillary light reflex. For visual acuity, we use Snellen's chart. Test each eye separately and ask the patient to read smallest line they can see. If the patient cannot read the chart, we can use progressively simpler method such as counting fingers or detecting hand movements depending on the clinical situation. Next, we assess visual field. One simple bedside method is confrontation testing. The examiner and patient sit facing each other and the patient's visual field is compared with the examiner's. Ishihara chart can be used to assess the color, or in clinical setting, the patients are asked to recognize the color of sheets. For example, blue, green, red. Finally, we assess the pupillary light reflex. When light is shown into one eye, the pupil should constrict. This is direct response. At the same time, the opposite pupil also should constrict. That is our consensual response. So, when examining the pupils, don't just look for constriction. Think about the pathway, which eye was stimulated, was the direct response present, was the consensual response present. This helps us understand whether the problem lies in afferent or efferent limb of the reflex. While examining the eyes, you will often hear the term PERLA, which stands for pupils equal, round, reactive to light and accommodation. It is a useful way of summarizing the basic pupillary examination. But remember, PERLA is not substitute for examining the pupils properly. Compare both pupils for size and shape. Check their response to light and assess accommodation when indicated. Now we come to cranial nerve 3, 4, 6. These nerves work together to control eye movement, so they are generally examined together. One common bedside test is H test. Ask the patient to keep their head still and follow your finger using only their eyes. Move the target through the different direction and observe both eyes. We are looking for restriction of movement, asymmetry, diplopia, abnormal eye position, and nystagmus. Here's a very useful memory aid. LR6 SO4 thrice. So, lateral rectus is supplied by cranial nerve 6, superior oblique is supplied by cranial nerve 4, and mostly remaining extraocular muscles are supplied by cranial nerve 3. A third nerve palsy may produce ptosis, abnormality of pupil and classic down and out position of the eye. So when eye movement is abnormal, don't just identify the direction that is restricted. Think which muscle normally produces that movement and which cranial nerve supplies that muscle. Now, let's move to cranial nerve 5, the trigeminal nerve. The trigeminal nerve is a mixed nerve with both sensory and motor function. Its sensory distribution is divided into three major divisions: ophthalmic, maxillary, and mandibular. To assess facial sensation, compare corresponding areas on both sides of the face. Depending on the clinical situation, light touch and pinprick can be assessed. Next, we assess the motor component. Ask the patient to clench their teeth while you palpate the masseter and temporalis muscle. You can also assess jaw movement against the resistance. Another important test associated with cranial nerve 5 is corneal reflex. The afferent limb is carried mainly by ophthalmic division of cranial nerve 5. The efferent limb is carried by cranial nerve 7. Next is cranial nerve 7, the facial nerve. And this is one of the most important cranial nerves to examine clinically. The facial nerve controls the muscles of facial expression and also carries other functions, including taste from the anterior two-thirds of the tongue. For the motor examination, ask the patient to raise their eyebrow, close their eyes tightly, show their teeth, smile, and puff out their cheeks. As you perform these movements, look carefully for facial asymmetry. Now comes up very important clinical distinction: UMN versus LMN facial weakness. In a unilateral UMN lesion, there is weakness of the contralateral lower face while forehead movement is relatively preserved. This is because the upper part of facial motor nucleus receives bilateral cortical input. In contrast, an LMN lesion affecting the facial nerve or nucleus causes weakness of both the upper and lower face of the same side. So remember, UMN contralateral lower facial weakness with relative forehead sparing, LMN ipsilateral weakness of entire side of the face. This distinction is extremely important when you are localizing a facial lesion. Now let's examine cranial nerve 8, the vestibulocochlear nerve. It has two major components: the cochlear component for hearing and vestibular component for balance and equilibrium. For a simple bedside hearing screening, we can use whispered numbers or sound of watch clicking or finger rubbing. Test each ear separately. If hearing impairment is suspected, tuning fork test can help differentiate conductive from sensory neural hearing loss. The two classical tests are Weber and Rini. Let's start with Rini. We compare bone conduction with air conduction. Normally, air conduction is greater than bone conduction. So, air conduction greater than bone conduction is normal finding. If bone conduction is greater than or equal to air conduction, this suggests a conductive hearing loss in that ear. Now, the Weber's test. Place the vibrating tuning fork at the midline and ask the patient where they hear the sound. In a typical conductive hearing loss, the sound lateralizes towards the affected ear. In a typical unilateral sensory neural hearing loss, it lateralizes towards better hearing ear. The vestibular component can be assessed further through appropriate balance and eye movement examination depending on the clinical presentation. Next are cranial nerve 9 and 10, the glossopharyngeal nerve and the vagus nerve. These two nerves are usually assessed together because they have closely related roles in swallowing, pharyngeal function, palate movement, and voice. First, listen to the patient's voice. Look for hoarseness, nasal speech, or other changes in phonation. Next, ask the patient to swallow. Difficulty swallowing, coughing during swallowing, or
What did you
other
have
signs
for
of
breakfast?
aspiration can indicate dysfunction of these pathways. Then ask the patient to open their mouth and say
Can you
ah.
tell ah?
Observe the elevation of soft palate and the position of uvula. Normally, the palate elevates symmetrically with unilateral palatal weakness. The uvula is pulled towards the intact side. Finally, we have the gag reflex. Remember, ninth is the afferent limb and 10th is the efferent limb. However, An absent gag reflex by itself does not necessarily indicate pathology because the gag reflex can be absent in healthy individual. Therefore, always interpret it together with swallowing, voice, palatal movement and the rest of the neurological examination. Next is cranial nerve 11, the accessory nerve. It primarily supplies the sternocleidomastoid and upper trapezius muscle. To assess the trapezius, ask the patient to shrug their shoulder against the resistance. Compare both the sides for strength and muscle bulk. To assess the sternocleidomastoid, ask the patient to turn their head against resistance while you palpate the contracting muscle. Finally, we have cranial nerve 12, the hypoglossal nerve. Cranial nerve 12 is primarily a motor nerve supplying the muscles responsible for tongue movement. First, ask the patient to open their mouth and protrude their tongue and observe, is it midline? Does it deviate? Is there wasting? Are there fasciculations? Then ask the patient to move the tongue from side to side. We can also assess tongue strength by asking the patient to push their tongue against the inside of the cheek while we provide resistance from outside. Now comes another important localization point. With a unilateral element lesion of hypoglossal nerve, the tongue deviates towards the side of lesion and there may be atrophy and fasciculation. With unilateral UMN lesion, the tongue generally deviates away from the cortical lesion. So remember, LMN tongue deviates towards the lesion, UMN tongue deviates away from the lesion. This simple observation can provide valuable information about the hypoglossal nerve. Now let's quickly run through all 12 cranial nerves. Cranial nerve 1, which is olfactory nerve, is responsible for smell. Cranial nerve 2, optic, is responsible for vision, whereas 3, 4, 6 is responsible for movement of eyes. Cranial nerve 5 is a trigeminal nerve responsible for facial sensation and mastication. Cranial nerve 7 is responsible for facial expression. Cranial nerve 8 is responsible for hearing and balance. Cranial nerve 9 and 10, glossopharyngeal vagus, are responsible for swallowing and speech. Cranial nerve 11 is for shoulder shrug and head rotation. Cranial nerve 12 is for the tongue movement. And remember, don't learn these as 12 isolated names. Think about function, test, finding, and localization. That's the easiest way to understand cranial nerve examination. And that's our complete bedside overview of cranial nerve examination. Remember, the goal isn't simply memorize the 12 cranial nerves and their test. The real goal is to understand what each nerve does, how to test it, and what an abnormal finding tells you about nervous system. If you are a physiotherapy, medical, nursing, or allied health student preparing for practical examination or clinical posting, save this video and come back to it whenever you need a quick revision. If you find this video useful, make sure to like, share and subscribe to Visual Physio for more clinically focused content on neurological examination, assessment and physiotherapy.